Good morning, everybody. My name is Jens Chapman. I'm speaking to you from the wonderful SSF facilities on July 15, 2020. It's the middle of summer here, and it's a beautiful day outside. And on behalf of our colleagues, Drs. Abdul Jabbar, Dr. Hart, Oskuyan, and Rowe, we welcome you here. We have our great fellows presenting some cases today. We're going to finally conclude the odontoid fracture topic, which has been a cliffhanger over the last couple of COVID months. And we'll then march down on the next couple of STED talks to our lower fractures, to the subaxial spine, hangman's fracture, etc. In terms of disclosures, I have no commercial disclosures relative to this talk. These are parts of our STED talks, which means spine technology education and the triple Ds of discovery, discussion, and debate. And again, the odontoid fractures couldn't be completed the last time because we were in our improvised COVID lectures, and we're still there. Again, in our facilities here, we have several of our faculty and fellows sitting there, and we're all socially distanced. So the cliffhanger the last time was that we didn't really talk about the treatment of odontoid fractures. A very brief summary as to what we had found, and this is now published in the European Spine Journal under Ronan Butcher's work. Odontoid fractures are on the rise. So if you look at this timeline, which is on the x-axis, the blue demarcates that cervical spine fractures in elderly patients are on the rise. And again, this is a distinct difference, if you can keep your eyes on the blue line, compared to the orange line, which shows, for instance, general other fractures in discharged people. And the patient population that is by far most affected are the elderly. So if you look at the golden line on the top, the golden girls is a good representative of that. The older age group of the 70 to 80-year-olds are by far numerically the most contributing cohort towards this rise in fractures. And if we then subspecially looked at this odontoid fractures, so C2 fractures were by far the main cause of problems. So this is the topic today. We've talked about diagnosis and assessment strategies in the past. And again, this is a representative, a very recent story. 83-year-old, very avid gardener, fell on his head, had neck pain, and this is an odontoid fracture, a type 2 oblique fracture, an AO type A2 fracture probably. And again, this is the problem. We put him into a collar. He didn't have much pain. He was neurologically intact. We treated him for 3 months. And this is something we very much emphasize in our practices, put him into PT, put him into balance training, fall prevention, posture. He actually did great until he kept falling and falling and falling. And this is a suboccipital hematoma that he had, and he's now had 3 major falls. He just came in a couple of nights ago, and he yet again fell on his head, and now his odontoid is tipping off finally. So we thought this was going to be a success story. This is a saga of over half a year. Since his suboccipital fracture and hematoma, where he got a craniotomy, he's never been quite the same. He is neurocognitively pretty with it, but not totally with it, but he wants to live independently. He wants to be out in his garden, which is apparently a large one. He does not want to go into a care facility, and he keeps falling. So now we have another and now displaced, non-operatively treated odontoid fracture. I thought it was going to be a success. This is an ongoing saga. This is a summary slide from our last session. This was mainly a fracture of elderly patients, as we've now shown in our state database assessment published in European Spine Journal. It's a low-impact trauma, so one of the most deadly accident mechanisms in terms of spines is a simple fall on your head in an elderly patient with some comorbidities, and the mortality rate is probably about a third of patients within about a year. And they can be missed very easily. And the key problem, as we showed in the past, is osteoporosis, which is expected in an age-related fashion around the base of the odontoid. And it's a pivot point mechanically for about half of our rotation of our neck. And if patients get arthritis in their joints between the atlas and the odontoid tip, the intact C1, C2 joints that you can see right there will still allow for some rotation, and that'll just break down in the odontoid base. So that's the biomechanical setting. You've seen the odontoid fracture classification, which our fellows are going to present later again. And again, the new classification that we developed with AO hopefully will become a mainstay, but we still stay with the old Anderson-D'Alonzo classification. We talked about non-operative options the last time also, and again, the classic one is either a hard collar, kind of a benign neglect in very feeble patients, keeping them comfortable, or a halo. And again, halos have been bedeviled, but in a Harborview study published by Rick Bransford, about a quarter of patients failed. That's by far largest prospective study, so it's not as bad as people said. The complications were not terrible in our very regimented cohort, but a fourth of patients fails basically. And if you want to see this as a failure, that's okay. If you want to see it as a success potential to avoid surgery, that's a different view. The forecast is that this is, again, a big deal, and surgery has become clearly more popular. There's a publication we did a couple of years ago, and you can show on the x-axis, again, the progression of time, and over time, the probability of surgery, which we did in a cohort in the East Coast, and we can see that surgery clearly became a preferred method. So this is the cliffhanger that we left with the last time, and now the question is what surgery that we're going to talk about today, and we have a number of options: anterior, posterior, wires, cables, screws, rods, fusion or not fusion. One big question was always, are alternate strategies such as, for instance, translaminar screws that we can put into the lamina as strong as others? And again, they're not quite as strong in rotation. The goal, the beauty would be to put a screw into the odontoid, and I think one of our fellows, Dr. Goodmanson later, is going to show one. We've also learned to look at certain fracture patterns as not being very amenable towards fractures. So when you see this case later by Dr. Goodmanson, keep your eyes on whether this was a suitable fracture for this kind of a fixation or not. I love this kind of a surgery. It's a very precise, very atraumatic surgery. You need 2 C-arms usually. You need to have a very experienced C-arm tech setup so that you can get those 2 C-arms in directly and then get a nice reduction. There are certain patients, like large people, who are clearly not amenable towards this. The approach is very clean, and again, patients can have a very atraumatic actual fracture repair done. And this is a case in question. Now, one of the big questions was, can these patients actually maintain rotation? And the answer to this is no. They actually don't really maintain normal rotation. Everything kind of scars down. And Benny Jeanneret, who's now recently retired from Switzerland, did a very nice rotation study. Again, I'm doing my rotation with my head here, with CTs, and showed that no normal motion is retained after this. So despite best efforts, it's not there. Devil's in the detail, and again, Dr. Benzel showed that very nice in his wonderful book on biomechanics of spine fixation. You need to be absolutely precise, and if you're not precise in your decision-making and surgical execution, like here, where the screw was just placed a little bit too anterior, it'll break out and it'll fail. And you'll end up doing a fusion in the end. So this is the common problem. One other thing that we saw when we did a prospective study with AO is a very important one, and that's, while it's very atraumatic and you lose very little blood compared to a posterior surgery, you're right behind the esophagus in an elderly patient. And there's a structure called the superior laryngeal plexus right in front of it. And if you retract backwards to try to get to that area, you may have problems in terms of aspiration and swallowing. And these are, again, some of the case examples. And this is, again, a specific thing to the upper cervical spine that means C3 and above. So this is what our study showed, and that is, again, if we compared, for instance, surgery and non-surgery, and then anterior versus non-anterior surgery, we saw that there were far more postoperative airway problems with anterior surgery. So if you look at the green field, that means that people had swallowing and vocal cord problems and hoarseness. And again, the green field is much larger in the anterior versus posterior group. If I go back one slide, patients did have some problems regardless of what treatment. That's probably simply due to the hematoma that forms in that fracture area. In a mini meta-analysis that we published a couple of years ago with odontoid screws, we saw that complications were far more common than what was really anticipated. And probably about 15% of patients had significant failures. And that's, with some of those names there, those are some of the premier names in spine surgery, at least in the last couple of decades. And again, even in those hands, there were significant complications with odontoid fractures, which makes the question very relevant of if this is still an applicable technique. And again, we'll show some cases later to enhance the discussion on that. If we go from posterior, we have to really understand the anatomy of the patient, specifically those little red things called the vertebral arteries and how they course through the bone there, which is an anatomic miracle in terms of the so-called V2 to V3 and V4 segment changes. And again, understanding this unique anatomic arrangement of these important arteries, how they kind of have this double tortuosity, this bend, this makes any Grand Prix course look like nothing. That's one of the key things in terms of successfully instrumenting that. I think without a question for us in spine surgery, one of the true breakthrough developments happened on 2 different continents in 2 different decades. Drs. Goel, a neurosurgeon from India, and Dr. Jürgen Harms from Germany identified this possibility to put screws selectively into C1 and C2 to get the spine stabilized from the back and fuse it. And again, one of our fellows, Dr. Moisey, did a very nice anatomy study and actually showed how you don't have to sacrifice the C2 root by putting the screws into the posterior arch, very carefully protecting the artery in its V3 section. And so you don't have to go through a bloody dissection and sacrifice of the C2 root. And on the top, you can see the so-called palm screws, PALM. He did show in an anatomic comparison study on cadavers that this is actually a safer screw and a more predictable screw to place than the standard lateral mass screws. We did get a response from a colleague, and again, he identified very helpfully that there are a number of things to look for, especially the so-called ponticulus posticus, the posterior arch of C1 that is closed that may obscure the vertebral artery and may make drilling of a C1 arch dangerous if you're not aware of this. So if you look at this again in a study that we did a couple of years ago with some of my colleagues from Philadelphia, we looked at preferences over time. And again, what we saw was that if we look at this kind of a field over the timeline, which is the x-axis again, number 5 are craniocervical fusions on the very top, and they're kind of falling out of favor. Odontoid screws are in the number 1 field at the very bottom, and they're also falling out of favor. And by far the largest field is number 2, so that's the second field from the bottom, which is gaining massive popularity over anything else. So there's been a clear selection by surgeons simply over time in terms of using this technique clinically. Again, we looked at a number of patients and over time, and again, we looked at this in terms of death rates. And again, we did find that death is increasing statistically speaking, but most patients can return to a reasonably functional time, but they do frequently require nursing homes. And why is that? This is clearly age dependent. So the older the patients are here, you can see this cluster of 80 and 90-year-olds that was in a national sample study. We really are dealing with a aging and a demographic shift problem. We did a prospective study with AO Spine North America on 322 patients. This is a controlled study, so that means we had a proper follow-up done just like it was an experimental setup study, which it wasn't. We did care as usual by patient preference. And again, we looked at discharge data, we looked at what was done, and again, odontoid screws are very rare, but a third of patients had posterior fusions, and over half of the patients had non-operative treatment. And again, these are some of the demographics and discharge criteria. And we did find that on surgically treated patients, the hospital stay was much longer than on non-operatively treated patients. We did also find that feeding tube placement was done in 18%, which will play a role. And we did find that discharge disposition for non-operative patients was far more in terms of death. So we found far more deaths in the non-operatively treated group, which led us to do a survivorship analysis, and this is in days, number of days afterwards. And we found a clear, distinct difference in terms of surgically treated patients doing better, meaning have less and lower death rates than non-surgically treated patients. Now, of course, the question of selection bias is a very big one. We looked at a number of variables, and we did not find a big difference in terms of the variables of health of patients. So surgeons, while they may be prompted by the health of a patient to make a decision, were not dispositioned by ill health of the patients. One of the most important things that we found was, again, age is a factor, obviously. The sicker a patient is, the more likely they're going to pass away. And again, if a feeding tube was placed. Now, this is a weird thing. Why a feeding tube? There's no question that a lot of these patients are of ill health and are malnourished. And the intent was to try to help them by putting a feeding tube into them to optimize the outcome, regardless of whether it was surgical or non-surgically treated patients. And again, this led to a much higher rate of aspiration. So when we looked at everything, all those variables that may influence our decision-making and statistically modeled it, the difference actually became even more crass. So surgically treated patients had a better survival chance than non-surgically treated patients. But what we found that's a big problem in terms of long-term survival that was replicated by our friends at Washington. We're very pleased to have one of our colleagues, Dr. Rick Price now from Washi here with us. They did identify that old age, disease state, and dementia were adverse predictors. Another thing that we found in Harborview when we did a study on older patients was the so-called Vulture Neck. So as we looked at the alignment of the cranium relative to C7, we found that patients, irregardless of their treatment, would drift forwards. And Dr. Hart is here in the audience, and maybe he can comment on that later. This is a really fascinating finding, and it does lend credence to the thought that probably patients, irregardless of whether they're treated in surgical fashion or with a collar, would lose their few neck muscles that they had. And if they're older, the head would start drifting forwards, which is a really big problem. So we labeled this the Vulture Neck, which leads to a lot of secondary undesirable phenomena such as pain and a higher fall propensity, because the center of gravity of your head is then in front of your trunk, and if something makes you stumble, you'll fall forward. So avoiding disuse of the neck muscles through whatever your treatment choice is probably a big deal. And yes, we did find a significant relationship to pain and falls later on. So here we go again, 95-year-old patient, and again, lives by herself, crashed a car at 60. These are the real-life problems we face now. She is neurologically intact, so she has an ASIA-E motor score 100, has no head trauma. What are we going to do? Are we going to do surgery or not? I'm going to just ask by a show of hands, the audience, you can't see them probably right now, and we're not going to go on the microphone until we have the cases. Who would favor just a collar by show of hands? We have 10 people in the audience, so anybody with a collar? 95, but living by herself. 3, 4 said collar. Who says surgery? Should be 6. Let's do the reverse test. Maybe some don't care. Only 4 raised their hands. Did you raise your hand, Cliff? What did you say? You didn't raise your hand at all. Surgery. You said surgery? Surgery. He said surgery. Okay, so we have a split audience. We have equipoise. So this is exactly the problem that we had. We did surgery on her, and she actually did very well. And my clinic staff said she was the happiest patient of the day. 1 year later, she lived. You know what? This was a very big decision for us. We did not take this lightly. We involved family. We had multiple discussions. The surgery was actually very easy to do. It was not easy, but it was relatively easy compared to the decision-making that went into this, because we had multiple people done. So who benefits from surgery? What really matters? And again, I will switch out of my talk now and maybe invite Dr. Goodmanson, since I announced him earlier, to talk. And Cliff, we'll come back to this later. I'll ask Dr. Cliff Pierre, to talk later about what this all means and how to put it together. And you'll have to clip in a laptop?
I think so.
Okay. Lee, can he do it by himself, or can you help us with that?
I think I can do it as long as this is the right plug-in.
Is this the right plug-in? Okay.
Okay.
I'll put my mask on and surrender the field.
All right, I'm Ryan Goodmanson. I'm one of the fellows here, and we'll just talk about a quick case of a odontoid fracture. Don't want that. So this is a 60-year-old male. He has a history of a fall from standing around July of last year. He was found to have a type 2 odontoid fracture at that time, which was treated conservatively up until now. The patient has a history of nicotine use and abuse, and he's continued to have pain now over the last 6 months. So these are his initial films. This is a CT scan showing a type 2 odontoid fracture. It's a little bit atypical, and that extends a little bit lower into the body anteriorly, but that is lending to kind of the reverse obliquity of this fracture, which, as you'll see, is something that Dr. Chapman had talked about for odontoid screw fixation. But you can see that there's a little bit of a reverse obliquity of this fracture, but otherwise well aligned, doesn't seem to have moved anywhere. And flexion extension x-rays show that it is stable with no other ligamentous injury. So this is a CT scan of him from about 2 months later. You can see that there is some osteolysis that's happening around that fracture, and it just doesn't seem to be uniting like you maybe would want it to. It's still maintaining alignment, although it is slipping into a little bit of kyphosis in that area, but overall is doing pretty well. This is then him around the 6-month mark. This would be essentially non-union at this point of this fracture, and he's still having a lot of pain. That's one of the things to note with him, is that he continued to have pain with this. And so it was essentially at this point a non-union of this fracture, and we had a discussion with the patient because he was unhappy with his current situation. At that point, we had actually got him off of nicotine. He had stopped smoking, and we kind of discussed two different options with him. We discussed the option of doing a posterior fusion with him, but did offer him an anterior osteosynthesis, and the patient did actually decide to try this route. And so we did plan for a C2 anterior osteosynthesis screw, which was performed. The patient did very well from this surgery. He had really no issues. He went home the next day after surgery and continued to do well. This is his 4-month post-operative CT, and you can see that he has union across that fracture site with a well-placed screw, maintained alignment, and the patient is extremely happy at this point.
So go back to the original one. Mm-hmm. I'm always a bit jealous of Dr. Hart. My partner here was sitting right in the next row, and we're socially distanced by about 5 feet. That's why I'm wearing my mask. Dr. Hart has one of the most quoted papers in odontoid fractures with collars. So, and that's a totally different patient population, was an elderly, but still, it was very thought-provoking because it did kind of raise the issue of how much does this little bone actually matter. So when, where, how is kind of a benign neglect apropos. And you now know what this patient was treated with. He was a risk factor patient, both smoking-wise and fracture pattern-wise. What would your thoughts have been in terms of a logical progression? So first, a two-part question, unfair compound question, but number one, when is just a benign neglect apropos and what patient population and what do you look for? And then secondly, talk us through your thoughts as to treatment.
So you're very kind to refer to that paper as a landmark paper. It was a small series of, I think, about 5 or 6 patients that Chuck Clark had followed for years. And those were patients, though, that came in with a non-union. So just to be clear, these were not patients that were followed with an acute fracture. They were followed with a new diagnosis of a non-union, and none of them ever developed myelopathy. That was really the point of that paper. And we do know that some do develop myelopathy. That is also true. So the decision-making is always complex. So this patient, to me, as I'm looking at it, I'm thinking the C1, C2 joint is already arthritic, if not ankylosed. I think not ankylosed, but with showing quite advanced arthritis. This would be one for me that my routine protocol is to treat patients initially in a hard collar for 3 months if they're neurologically intact and safe to do so, and if that's the family preference. So my guidance is usually towards conservative treatment for 3 months, as was done here. And if the patient then develops a non-union, we have another discussion, and the decision of whether to intervene surgically is reintroduced. And in this patient, I think I would have chosen a C1, C2 fusion posteriorly. I applaud your results. It looks great. So the decision making, I can't fault that. I've done some odontoid screws. I did them when they sort of were popular or more popular a few years ago, and I had very mixed results. So I think I had at least a 50% non-union rate, and I kind of gave up on that. And the other aspect of it, I think, is what Jens really was describing. We've found that a C1, C2 fusion, particularly in an elderly population, and to me, particularly in a patient like this with arthrosis already present, is a relatively relatively safe and relatively effective and well tolerated by an elderly population. So those are my thoughts. But nice outcome. I will say, looking at this, he's a good patient to consider the anterior screw, because if you look at the base of the odontoid, a lot of these patients will have lysis and osteoporosis right through the fracture line and into the base, and those are the ones that are most susceptible, I think, to break out of the screws. And he looks like he has pretty good maintenance of the trabeculae in the base of C2.
Great discussion, thank you. So Dr. Skurian's the chief of our spine service, and he's in the hot seat now because he did, I'm going to give you the microphone, because Dr. Hart felt that this patient might have been better treated with fusion. And again, I'll put the same gauntlet out at you. Reverse obliquity fracture and patient with nicotine use, which means bad bone healing. So here's the microphone.
So this was a challenging case because he actually was a fully functioning, good citizen, and what was interesting is his symptoms actually got worse to the point where, and he admitted that he really didn't wear his collar for the first 3 months, but then he wore it for and so I saw him at the 6-month mark, and there's some controversy with, if you look at the published data, they don't actually recommend doing these after 6 months. 6 months is kind of what people say is the cutoff for doing an odontoid screw. And he did actually quit smoking before we did it. So that delayed it another 90 days. But I just told him, I said, look, I'm not going to operate on you if you're smoking. But he really wanted to potentially preserve motion, and again, there's some controversy as to how much motion you preserve after the surgery, but I actually was on the fence about whether to do this or not with an odontoid screw, and he was a pretty big guy, so he had a barrel chest, so the surgery technically was not easy, but I've done probably 2 or 3, and they've all been kind of at the 6-month mark. And if you look at him, his C1 is kind of fused to C2. So in his flexion extension x-rays, he actually moved quite a bit. And so he would get this Lermite sign, if he extended his head. So I think in his situation, I think actually it was a lot more unstable than what the images showed. Like you can see on his flexion extension, the peg really anteriorly translates, and then when you go posteriorly, you could see it move quite a bit. Knock on wood, he healed, but he slept in his collar after surgery. So I think that helped, and I think, nicotine, he lost weight. I mean, we did a lot of things to kind of help him prehab, but it wasn't an easy decision.
Ryan, do you mind using the cursor and just showing everybody the atlas odontoid arthritis that Dr. Hart was talking about? Because, again, if you look at the C1, C2 joints, the atlantoaxial joints left and right, they're actually pretty nice looking. But for some reason, I still don't know why that happens. If you just use the cursor, yeah, there's arthritis here. Dr. Hart pointed that out. So something is wrong with that odontoid relative to the atlas joint. But what that matters in terms of clinical everyday symptoms, we don't know. But what it does do, it creates a pivot point effect on the base of the odontoid. So can you go forward again to the final film? So one of the key things here, again, this is beautifully done, Rod. You want to recess the screw into the disc space actually of C2-3. So that's my only kind of a technical point. If you can put the cursor on the tip of that screw, right there, the screw head. So again, this is done very well. Usually we want to try to get the screw buried almost into the top of C3, so you can actually excise the annulus seemingly with impunity and drive the screw more vertical. The reality is, if you have a large barrel-chested patient, you can't get that angle. And that's, again, one of the main problems. But this is perfectly executed, perfectly done, and obviously congratulations on that nice outcome. But yeah, no, it does show a lot of the decision-making questions. Let's invite Dr. Jimenez to come up and show a different version. So thank you, Ryan. And can you plug in the other laptop?
Yes, sir.
It's my pleasure to introduce, I'm not going to get up here, Dr. Lincoln Jimenez, who has a different odontoid fracture prepared for discussion. And whilst he's getting set up, Rod, I'll give you the microphone back. Can you tell us, did you use a 2 C-arm setup? What'd you do?
Yeah, we actually use the 2 C-arm setup. You know, I use a Radiolucent Mayfield headrest. And then, you know, you kind of have to play around with it a little bit, but usually you can get a pretty nice open mouth view. And then obviously you want to have a good lateral view when you're shooting as well. And I think you pointed this out, you really want to try to get the guide into the disc space. And anatomy helps you. And this guy, he was so barrel-chested, it was very difficult to get into it. But and we make an incision. It's usually at C4-5. And again, if you're a right-handed surgeon, usually you make the incision on the right hand. If you're left-handed, you go from the left side. So.
Great technical points. Dr. Jimenez, show us another case.
Good morning, everyone. So this case is interesting because it brings up which patients do we have to actually choose to do surgery or conservative. In this case, actually was a patient that we chose to do conservative treatment initially. Oh, sorry. And we thought that the patient was going to be doing well. And in fact, the patient did well, but unfortunately, progressively, imaging and clinically wise, the patient unfortunately did not do at the end too good that we end up doing surgery. So this patient is a 72-year-old male who came with posterior neck pain. Unfortunately, the patient had also been having some issues with gait dysfunction just because the patient had history of Huntington's disease, as well as shortness of breath and some problems to swallow. Patient is shown in there, had multiple surgeries, and among other things, the patient did have some high blood pressure and arthritis. All the things that are important about this first slide is that the patient was also a chronic smoker. So over here, what we see, we have on the left side, up picture, we have a, and where's the remote? Okay. Right here. We have on this CT scan a fracture which is not complete of the odontoid tip itself, and we see it actually also on the coronal picture on the CAT scan, and we see that there's really no major displacement of that odontoid fracture. We considered that fracture back in November 2018 and December 2019 as an M3NX, and on the Grower scale at 2B. Unfortunately, the patient is a patient who has some social issues and was a non-compliant patient, and the patient continued. This is just a run of the CT scan. See. Yeah. Right there, it shows that the alignment of the odontoid is actually adequate. There's no major displacement, and there's no major gap of that. So in February, actually, the patient did have just slight resorption of that bone over there, and we were seeing that the gap was actually increasing, but still we decided to just continue observing. However, the patient clinically was not doing too good. The neck pain was actually worsening, and In June, unfortunately, as we see here, there's much more resorption of that fracture. Although there's no major displacement, the patient was already showing the signs and symptoms that I mentioned in the first slide. At that time, the decision was to try to stabilize this patient because we thought that the next thing was going to be a patient having much more major neurological deficits. So why do we think this patient may have failed? It's possible that the patient, despite the fact that did not have a major gap, maybe the smoking was one of the issues. The other thing is that definitely this was a chronic fracture that eventually was resorbing much bone. And also, based on the studies, being male, the patient to have a higher chance of non-union. And among that, of course, the patient was non-compliant to his collar, so that makes it way difficult for this patient to have a non-union. So we decided to proceed with surgery. In this case, what was done was a C2, C1 fusion with lateral masses on C1 and pedicle screws at the C2 level. The patient actually did perform very well. The symptoms did improve significantly. Unfortunately, the patient continues to smoke, although he lives independently.
Thank you for this very succinct and insightful case discussion. Did you, in your review of this case, Dr. Jimenez, identify the blood loss of that surgery? Do you have any gestalt of that?
Yeah, it was stated as, I think it was 150 to 200 based on what I saw there.
How did the surgeon fuse the patient? So he instrumented the patient, but how was the actual arthrodesis effort done? Because I don't see any bone in the joint. So was a bone graft put on? Was any effort made to try to get a formal fusion that you could see?
Just the bone graft that we have in the, from the companies that we have there. And I think there was some bone taken from the spinal process, but it was minimal. Yeah.
So it was just a posterior arch fusion?
Correct.
Okay.
Correct.
Go back to the initial fracture, if you will.
Yeah.
I'm going to ask Dr. Hart a question. Yeah, go back a little bit more. So we had an almost non-displaced fracture here, Bob. And then, so everybody sees how that little crack is there. And then if you go 2 slides forwards, I think it was 2 slides, go advance, please.
Yeah, I'm trying to, right there.
Yep, and still pretty non-displaced, then go 1 slide forward. Suddenly we have this large resorption. Dr. Hart, why does this happen? I mean, this is a non-displaced fracture, and why this substantial resorption of bone? What's the osteologic basis of this resorption?
Well, that's I think $1 million question. I think what contributed here probably is smoking status. If you look at C1, C2 again, it's nearly ankylosed, so I think the forces across the fracture line are increased in that setting. And I would say, we know that this is a difficult fracture to get to heal in any instance. And I do think immobilization here, I said I use that as my first treatment typically. I would have in this patient. I don't use halos. I would put him in a hard collar and ask him to wear that for 3 months. But I have to say the union rate is very low in geriatric patients with a type 2 odontoid fracture. It just is.
In your review of the case, Lincoln, did this patient have a very bad case of Huntington's? Was there a lot of extraneous motion, or?
It was actually being controlled, despite the fact that he's non-compliant, not a compliant patient with medical issues. He was controlled, but still he has some movement disorders, definitely. Yeah. So I think that the worst thing is that he didn't like to use a collar at all.
Patients with movement disorders usually don't like braces or collars, yeah. I found, because they have this ongoing involuntary motion. I've seen that in a lot of Parkinson's patients also, with arthrodesis movements. And again, dyskinesias really kind of rub them raw, literally. So with a rigid collar, this is not a benign thing. If you go back to the initial slide, now Rod, you showed your beautiful odontoid fracture. Go forward one, sorry. Applying the power of retrospectoscope, could this patient, knowing how unforgiving these little innocent-looking fractures in this finger-sized bone are. Knowing what you know, would a simple odontoid fracture fixation with an odontoid screw just have stopped this whole problem?
Probably not, because just because of the fracture pattern, and it's there's a very small amount of the odontoid left. I mean, this is a true type 2. And so I don't think this would heal. And then given the, the fact that the patient's got a neurodegenerative disorder, there's a lot of factors, I think, that play into this. And then, bone healing and age. I just think the fracture type on this probably is not a great candidate for an odontoid screw.
Do patients with Huntington's have a greater risk of dysphagia or some form of upper esophageal dysmotility? We have a neurologist here. I might put you on the spot if you're comfortable. Otherwise, I'll ask Dr. Do you want me to ask Dr. Oskuyan? Or do you want to talk about it? Can I bring the microphone to you? So Dr. Flesch is a neurology resident from Madigan. So sorry to put you on the spot like that. We need help from our neurology colleagues. Do Huntington's patients, what should we know about Huntington's in terms of dyskinesias and swallowing dysfunction, for instance? Is there something we should know?
Well, in terms of Huntington's patients, I mean, I'm actually shocked. I don't think I've ever seen a 72-year-old with Huntington's. So it's kind of advanced. So presumably his disease is either fairly, slowly progressive. But yeah, you can have higher rates of dysphagia in Huntington's patients. And then as you pointed out, sir, the dyskinesias can put different forces on, the cervical spine that you wouldn't expect in kind of a typical degenerative spine. Just a normal 72-year-old can have really, really bad arthrodesis movements and potentially even dystonic posturing that could put significant forces that would cause more degeneration than you would normally expect.
So thank you for your clarification. Again, for me as a surgical simpleton, what I'm hearing is an anterior neck surgery might not be a good idea because they may have a higher incidence of dysphagia and dysphagia. I mispronounced that, dysphagia and dysphagia. And maybe if we did something, a more biomechanically rigid fixation from the back of the neck would be preferable. Is that a fair surgical summarization? Thank you for letting me put you on the spot. Dr. Price is here from one of the most famous universities, WashU, St. Louis. What would you have done at WashU? You have a complex patient. Are you willing to give a statement? He's just arrived here from WashU for the year.
Yeah, I think at WashU we'd done exactly the same thing as was shown in this presentation. We'd put the patient a collar for 3 months, and if they don't heal with the collar, then do a C1-2 posterior spinal fusion. Fortunately, the patients in Missouri are usually limited by size for odontoid screws, so we usually do things from the back there.
One more question. I'll put you on the spot here. You don't know the background of the story, but you're kind of an impartial adjudicator. So if you go forwards to the fixation slide, and I actually don't know who the surgeon was, but it wasn't me. Keep going to this actual fixation. So this is beautifully done C1, C2 fixation. This is done in a traditional lateral mass fixation. That means the C2 root was taken. So at WashU, would you guys have taken the C2 root and done a traditional lateral mass? Would you preserve the C2 roots?
Surgeon preference. Certainly, if you take the C2 root, you don't have as much bleeding. So I think in an elderly patient, we'd probably take the C2 root to reduce blood loss.
So wait, so you say that by taking the C2 root, you don't lose as much blood?
No, it was
If you coagulate the plexus of veins around the root as well, then I've found that the blood loss is less than if you just try to retract the nerve root, try to put the screw in.
So we don't retract the nerve, but we actually preserve it. We drill higher up, but yeah. So that's just a technical point. Dr. Oskuyan, so C2 root here, I'll bring your microphone to you. He's one of the propagators. You have to use this microphone probably. C2 root does not play a role in a patient's happiness. So you think you can sacrifice it?
Oh yeah, we take it, and it allows for the arthrodesis to take place. And I always tell the patients, I tell them, you broke your neck, and you're going to have a numb. The back of your head's going to be numb. And it takes them about 6 months, but after about 6 months, they sort of, the numbness kind of goes away and it doesn't bother them. The first 6 months, it kind of irritates them a little bit, but I don't have any problems with it. And I think it allows for the fusion, really decorticate. And I'd like to put a piece of bone graft in there as well.
So Dr. Hart, I actually don't know the answer to this. Are you a nerve root preserver or are you a sacrificer?
So I like the starting point down on the back of the C1 facet rather than in the ring because I think it's safer. And I did that initially preserving the root, thinking that was the right thing to do, but I have gone to be 100% a root sacrificing surgeon. And I agree entirely with Dr. Oskulian's comments. You get some early discussions from patients, and I remember one sort of elderly Eastern Oregon cowboy that came back to me and said, "Doc, you turned me into a numbskull." So they do definitely notice it, but they either come to tolerate it or it improves over time with reinnervation from other sources. I don't know. But I also would underline what Dr. Oskulian was saying. It allows you access to the C1, C2 facet joints, which I think is a very reliable source of fusion then when you use that technique.
I'm an outlier, and maybe one of the incoming fellows can look at a comparison of patient happiness because I preserve the C2 root. I think it's less bleeding, and I can still do a C1, C2 arthrodesis. But let's ask Dr. Jimenez, what do you think? Are you going to, as you go into your new practice in San Juan, Puerto Rico, are you going to take the C2 root or are you going to preserve it?
Very likely, just because it makes it much easier. Most likely, I'm going to sacrifice.
Okay. All right. Thank you. So our next, one second, we have, I think, one more case, yeah. We'll ask Dr. Eric Heyman to come up. I'm not going to go to the podium. And he has a more dramatic case about an odontoid fracture with a significant adverse implication prior to treatment. So in my presentation, I didn't identify any major spinal cord injury associations. The spinal canal is very capacious, but there are a few, but very severe cases of spinal cord injuries. And this is a case, an example of how the odontoid fracture, if it's missed, can have severe adverse implications on a patient.
Hi, so my name is Eric Heyman, and as Dr. Chapman alluded to, I'll be talking about an atypical presentation of C2 fracture, a C2 fracture with a high spinal cord injury. To get started with the case, this is a 74-year-old female, history of some very mild Lewy body dementia very early, but a very functional woman, lived with her husband, who sustained a ground-level fall accompanied by cardiac arrest. She did have return of circulation after about 2 minutes due to rapid intervention form of CPR. But she was non-responsive at the outside hospital, lacking motor movement. This was interpreted as post-arrest encephalopathy. She was cooled for 3 days and then gradually warmed. During this time, during workup of her etiology of her cardiac arrest, she was found to be severely bradycardic to the point of requiring a temporary pacemaker wire. And this was eventually converted to a permanent pacer implant. And up until day 3, she was really interpreted as this was interpreted as a cardiac process. An elderly patient who had a cardiac arrest due to a bradyarrhythmia, and was having post-arrest encephalopathy. However, as she started to wake up, she was known to have several features which would argue against arrest encephalopathy. Despite not moving her lower extremities, she appeared to be responsive in terms of her facial movements, which were quite active. She had relatively intact brainstem reflexes. This prompted a CT angiogram, again, not to investigate spinal causes, but to rule out a pontine infarct, where she was found to have this relatively subacute to chronic appearing type 2 odontoid fracture. I think this highlights, this presentation is probably one of the more interesting aspects of this case, just because it highlights the fact that these are not necessarily benign injuries. Although we typically think of odontoid fractures as neurologically benign, with neurological dysfunction as a relatively rare presentation, if you look at autopsy series, high cervical spine fractures, such as odontoid fractures, are disproportionately represented in non-survivors. So The neurologically benign course of these injuries, I think, is more of a case of survivorship bias. The reason being, patients who sustain high cervical spine injuries, cord injuries, typically die at time of presentation, and most likely their diagnosis is missed, as this case. The reason why these injuries are so deadly are multifold. For one, C2 is well above the phrenic nerve control, leading to diaphragmatic paralysis. More importantly, loss of sympathetic tone can lead to overwhelming parasympathetic tone and sort of a quadriplegia coding effect, where they go into cardiac arrest due to unmitigated parasympathetic tone. Because of this late discovered spinal cord injury, she was transferred to Cherry Hill for further workup and to obtain MRI due to her pacemaker, which cannot be obtained at the outside hospital. She was transferred to Cherry Hill. On our exam, she was found to have an intact cough, but otherwise be motor complete, but apparently was sensory incomplete. When I examined her, she did have some grimacing to particularly sacral examination. Therefore, an emergent MRI was obtained, demonstrating diffuse cord edema spanning radially from the cervical medullary junction down to about C7. If you look at the axial images, there's a central hematoma behind C2, suggesting that this was the area of contusion, with the remainder of this edema being sort of spread of edema cranial-caudally, a well-known phenomenon, especially in higher grade spinal cord injuries. This edema was causing secondary stenosis at the lower C-spine, most notably at C5-6, where she had some pre-existing stenosis. So this is a patient who was presenting with a high spinal cord injury and facing the process of quadriplegia, but was nevertheless sensory incomplete and a previously active woman. This led to a very rapid but thorough family discussion where goals of care were discussed, and ultimately the family did decide to give her a shot, to give her a full court press. This was performed in the form of an occiput to T2 fusion. The procedure was uncomplicated with good hardware placement. However, despite decompression, the patient continued to worsen, demonstrating and compressive worsening mental status, as well as apparent loss of her sensory response. In addition, she appeared to be strictly valvular dependent without ability to really effectively initiate spontaneous breaths, so going from more of a tetra to a pentaplegia type picture. Repeat MRI was obtained, although the quality of this is sort of mitigated by the hardware artifact. Nevertheless, it showed further extension of edema despite good decompression, really into the base of the pons on post-day 10. Her failure to recover in progression from her spinal cord injury led to further goals of care discussion, and ultimately the decision was made to palliate this patient, and she expired after extubation.
Thank you for the sobering but very clear presentation. Do you mind going back to that MRI comparison? Yes. Very good juxtaposition. So from your previous institution, from shock trauma, from one of your attendings, comes one of the landmark papers on imaging on spinal cord injuries in the last decade. Dr. Arabi talked about how many levels or the length of a cord signal change being indicative of severity of cord injury, yes. Also of interparenchymal medullary hematoma having an adverse outcome. So can you look at that left-sided post-injury day 5 image and discuss briefly what you see there, and if this is an adverse prognostic thing using Bijan Arbabi's
yes.
classification?
Yes. So at shock trauma, Dr. Arabi, using MRI imaging, was able to identify a very different pattern of edema progression in mild spinal cord injuries, your Ds and Cs, versus your more complete type pictures, your As and Bs. Specifically, As and Bs go a much more rapid and much longer progression of their edema, both cranially and caudally. Based on this, his practice pattern was in complete injuries to compress 2 levels up and 2 levels down to perform a very extensive decompression for patients with A's and B's, whereas patients with milder injuries would get a much smaller decompression, usually over the foci of injury. This occurs relatively rapidly over 24 to 48 hours. Most likely this is multifactorial, although another neurosurgeon at our institution, Mark Samard, believes he has identified the molecular mediator of this phenomenon, specifically upregulation of a pathologic SCR1 TRPM4 channel, which leads to degradation of the blood-brain barrier and, at the focus of injury, actual loss of capillary integrity and frank bleeding. There is a medication to treat this, actually, one we're all familiar with, gliburide, anti-diabetic agent. It's shown some promise in stroke and is moving to phase 3 trials, but there's actually a small phase 1 trial going out of Ohio State looking at treatment of this sort of malignant edema after spinal cord injury using this treatment.
So, Dr. Hart, this is obviously a very sobering, challenging case. So, any thoughts in terms of surgery or not? We did take this decision-making very seriously with the family, had iterative discussions. Was this a futile case? And again, if you look at this in terms of going back to the odontoid fracture, this patient had neck pain for a while. She had some falling tendencies. Is this one of those situations where, had this been recognized and fixed, this might have been mitigated?
Well, it's impossible to know, but just a very sad case, obviously. I think I would have pushed, as I think you did, towards consideration of end-of-life care from the get-go. I mean, this is, the survivability of this severe of a spinal cord injury in an elderly patient is low. And I always draw the analogy to hip fracture patients. We know that hip fracture patients, about a third will have passed away within a year of their injury, and this is an even more debilitating injury, obviously, and putting the patient permanently in a wheelchair, or at least for a very long time in a wheelchair. Having said that, I think it's worth calling out the procedure you did. I think in a patient with a cord injury at the C2 level, and even in a milder cord injury, the central fibers at that level are the paraspinal muscles, and so a central spinal cord injury at the C2 level looks worst in the paraspinal cervical musculature, and so they end up developing a dropped head syndrome. So you can't manage it effectively with just a C1, C2 fusion. And I probably, in this patient, had we done surgery, I would have probably stopped at C1. We talked about that at the time, I remember, or shortly after. I would have done, I think, a C1, but also with a distal endpoint of T2, because you've got to maintain their head posture neutral and erect.
Thank you. Now, to conclude, over the last 5 minutes, I'll ask Dr. Cliff Pierre, a future neurosurgical attending, to come up to the podium and tell us what it all means to him. So put it together for us. This is kind of extemporizing, putting you on the spot. But you heard a lot of theoretical information. You saw some cases. I have one case of an 82-year-old male coming up. I put the synapse over the odontoid because I thought it kind of visually resembles one another. What matters in our decision-making process? You close us out from here. Thank you, Cliff.
Thank you, Dr. Chapman. Again, in the final minutes, as we come to a conclusion of the cliffhanger of odontoid fracture management, as discussed, as conservative and non-conservative options, taking age into a considerable factor, and especially in our elderly population, our geriatric population. And so again, in this case of an 82-year-old male with a ground level fall, in a retirement home, some things to consider, not only just the pathology of the fracture, the extent of the odontoid fracture, it being a type 2, type 3. This one, again, looks like there is significant displacement posteriorly, so I would be concerned for stability and would consider this an unstable fracture at this point. And one of the options, as we discussed throughout the day, was a surgical management for this. I would approach this more so from a posterior aspect. Again, we had discussed some of the odontoid screws earlier, and again, with the amount of displacement here, and again, the appearance of the bone quality, I'd approach this from a posterior approach, C1, C2. And again, taking into consideration of alignment, stability, the patient's exam, their age, and then prospective long-term outcomes for this patient. And so representative images of what was done. And then again, a great C1, C2 fusion was taking place.
You can go one more. I think we had like a 9-month, that's it, okay.
Yep.
So again, long-term follow-up. I think we have like a 9-month follow-up on him. He did okay, but is the C1, C2 going to be kind of what you're going to go as your go-to fixation then? Is that your
Yes.
take-home message?
Yes, that would be, it's, for me, in my wheelhouse, the go-to fixation. Again, in the right patient, right age, yes, considerations for odontoid screw just to maintain a more motion at this segment would be considered, but for me, it would be a posterior approach.
And it would interest me greatly, for you as a young surgeon, you've heard a couple of the older guys speak now. If a fracture is not so displaced in the future, would you try it in a collar for 3 months, or would
Yes.
you be more aggressive with surgery?
I would try for rigid collar for 3 months, a close follow-up. Again, any issues with significant pain not being resolved, any issues with any further decline in neurological symptoms, come see me right away, and then reevaluate with a scan, and then consider surgical options, especially if they have a non-union.
So my biggest request and challenge to you, our neurosurgical and neurologic colleagues, is to find a meaningful mental health test that we can apply in patients to see whether they will need and benefit from surgery or not. Because that's, for me, this
Yes.
beyond all fracture morphology, still the single biggest thing in terms of trying to help me guide a patient and their family as to surgery or not.
Gotcha.
So that's what my big request to you guys is, the next generation.
We'll work on it. Thanks. So again, this concludes our STED Talk for today, and I look forward to seeing you in 2 weeks. Thank you.
Thanks for watching. Hit the subscribe button for more medical content.